spical nodes were also dissected. HBR showed the specimen size was around 10 into 11 centimeter, and the closest cut margin was 0.4 centimeter from the skin. And the tumor size was 4.3 into 3.1 into 2.2 centimeter, and it was an high grade adenocarcinoma. So it was high grade invasive apocrine carcinoma, which occurs both in breast and skin, and hence it's impossible to confirm the site of origin. And based on the clinical details, it leaned more towards a skin tumor. Skin was ulcerated, and the subcutaneous tissue was also involved. LV, PNI were absent, and all nodes dissected were negative. And on IHC, it was strongly positive for androgen receptors. So the final histopath impression was it is an adenocarcinoma, poorly differentiating, favoring sweat gland adenocarcinoma. So the final diagnosis was this was a poorly differentiated apocrine adenocarcinoma of the sweat gland in right axilla. The patient was sent for RT opinion, and in view of complete excision, and the closest cut margin was 4 mm, and there were no positive lymph nodes. Adjuvant RT was not warranted, and this patient was then kept under observation. So finally, discussing about adnexal carcinomas. Sweat gland carcinomas, they are rare, and sweat gland can ecrine, apocrine, or apoecrine. They're diagnosed at around age of 50 to 70 years. Ecrine carcinoma, they occur mainly on skin of head and neck or extremities. They manifest as painless papules or nodules that grow slowly, and histologically they resemble carcinoma of breast, bronchus, kidney, and they are difficult to differentiate from cutaneous mets. Biology and pattern of spread. Ecrine carcinomas are aggressive as compared to SCC and BCC, and they show local recurrence and nodal relapse. Apocrine carcinoma, as we discussed, they commonly arise from apocrine glands in axilla, and other sites would be apocrine glands in vulva, eyelids, and ceruminal glands of EAC. They manifest as red, purple, firm or cystic dermal mass. Their natural history is not well documented, but nodal and distant mets have been reported. Microcystic adnexal carcinoma, they are also rare, and they are locally aggressive, and they belong to spectrum of adnexal carcinomas. They occur in mid-face, and they also grow slowly and are deeply invasive, and they occur in 55 to 60 years old. PNI has been reported in some cases, and lymph node mets rarely occur. Sebaceous carcinoma, they arise commonly from the sebaceous glands of ocular adnexa, the meibomian glands in the tarsus, and glands of Zeiss at the lid margin, and extraocular is an genitalia. For malignant neoplasms of eyelids, sebaceous carcinomas are second only to BCC in frequency, and they occur in individuals older than 60 years. They also manifest as slow-growing, non-tender, deep-seated firm nodules. They often present with chalazion or other inflammatory process like conjunctivitis, blepharitis, or tarsitis. And the clinical and pathological features indicate poor prognosis would be the size of the primary lesion, vascular or lymphatic invasion, poor sebaceous differentiation, and highly infiltrative growth. They behave more aggressively than SCC, and they have propensity of nodal and hematogenous spread. And the developing nodal mets would require regional surgery and adjuvant RT. So general treatment would be they would undergo wide local excision and therapeutic nodal dissection if lymphadenopathy is present. An excision can be wide local excision, or it can even be Mohs micrographic surgery. And generally, post-op RT is indicated when surgical margins are positive or close, or if multiple lymph nodes are involved, or if there is an extracapsular nodal extension. For ecrine and apocrine, a wide excision is accepted as standard treatment. And post-op RT to surgical bed would include 2 to 3 margins. And role of elective treatment of regional lymphatics is controversial for this rare disease, as most malignant skin adnexal neoplasms have low rate of nodal metastasis. So SLNB is not recommended. However, for if they have high risk features, then SLNB can be used. So a target volume would consist of a surgical bed with margins of 2 to 3 centimeter, depending on the site and the size of the primary tumor. And dose fractionation schedule would be 60 to 70 gray in 30 to 35 fractions, depending on site and the target volume. And these can also be reduced to encompass only the areas of gross disease after 50 to 54. This was another case which was similar to the one we saw in our OPD, and but this patient and the intercostobrachial nerve was involved, and the branch of the thoracodorsal vein was also involved. So, in view of these above factors, this patient received adjuvant CTRT with the 5-fluorouracil and RT to 50 gray in 5 weeks. So, the authors concluded that this is a rare tumor with restricted literature. The lymph node status might be the important predictor for survival, and SLNB may prove to be beneficial in these cases. There was lack of consensus about chemo and RT, and chemo that can be used as methotrexate, bleomycin, and 5-fluorouracil. Local RT will improve the most common site, and the most important thing to note is the differentiation for and early treatment. Now we'll be discussing some of the syndromes.
Sorry, just before you go to the syndromes, let us talk about the skin and neck cell tumors. So, in terms of presentation, before the biopsy, what is the main differential diagnosis you have before the biopsy? After the biopsy, once you have histology, then it's a different discussion. So, who's there? Amia is there with you, the third year JR?
Yes, sir.
Amia? So, in terms of making a clinico-radiological diagnosis, before his biopsy is taken, what are the main differential diagnoses?
So, sir, either it can be a benign tumor or it can be a malignant tumor. So, in benign, it could be a simple cyst or even a lipoma, or it could either be accessory breast tissue as well. Or
I'm not talking of only in the axillary tail region, in general, skin and neck cell tumors. It could be anywhere.
yes, sir.
So what is you are saying, like a lipoma or a cyst, what else?
Or it could be sir, tubercular lymph nodes, or either sarcoidosis, or in patients with HIV, they can be other lymph nodes or lymphomas.
Okay.
And then it could be, sir, metastasis from other site, primary site.
Okay. It could be metastasis from other primary site. Okay. Fair enough. Then, one important thing which you have not said, when would a sebaceous cyst could look like a cancer? Or when would any other cyst can look like a cancer? When they get infected or inflamed.
Yes, sir.
Okay. So benign thing, otherwise you will be able to differentiate, but if they get infected or inflamed, or they sort of separate or they ulcerate, then it could look like. So that is one thing. Then anything chronic like trauma or non-healing ulcers, sometimes they could also look like. So before histology, you have to keep in mind that these could occur at uncommon sites. The appearance, natural history is variable, and many a times benign lesions, especially like infected sebaceous cyst or anything which is there, inflamed or infected benign lesion may appear like a skin and neck cell tumor. So you cannot be sure. So histology, unlike what we discussed in occasionally in very elderly patient or a typical BCC, you have hardly any differential diagnosis, and there are occasions when you could treat them without biopsy also. It's not standard, but occasions. But a skin and neck cell tumor, there's a very wide range of differential diagnosis. So once you have done the biopsy and the histology is poorly differentiated adenocarcinoma, that's what most of the pathologists will initially write. unless until they have done a whole battery of IHCs or they have got a lot of feedback from the clinical. So then what are the things you have to keep in mind? So histology is poorly differentiated adenocarcinoma. So two major presentations. One is it's a truly a skin adnexal tumor. The other is, so it is a rare tumor which you are seeing, or it could be a rare manifestation of a common tumor. Okay, so it's a common cancer, but this is a rare manifestation, like as a skin, which is there. And rarely, normally adenocarcinoma lymph node mets do not ulcerate, but rarely you may have an ulcerated lymph node. Okay, that is unlike squamous carcinoma, lymph node mets, which could sometimes involve the skin and ulcerate. So these are the things you have to keep in mind. And that's why giving a clinical feedback is very important. And I think the history is very important. You'll be surprised how sometimes if you ask them and you give them time and you ask them properly, how much a patient can tell you about, because it is growing in their body. And if it is in a site where they can see directly with their eyes or in the mirror, or their spouse, someone can see them, they will describe how it sort of came, how it increased, how it started, and they will tell you exactly it was on the skin, very superficial, and then how it increased. So that is very important for you to know. Okay, and then of course you should know if patient has any other specific exposure or something else which could put them at risk for certain cancers. Okay, I think carry on now. Now you all are going to the rare tumor, isn't it?
Yes, sir.
Rare syndromic tumors. Okay. Okay.
Xeroderma pigmentosum. It's an autosomal recessive disorder of DNA repair characterized by sun sensitivity and UV radiation induced skin and mucous membrane cancers. So it clinically manifests as photosensitivity, actinic damage to.
Has any of you first year or second year residents seen an XP case? There are few XP cases which keep going to the hospital, but during lockdown, I have not seen them since the lockdown started. So your batch, has anyone seen a case of XP?
Sir, I have seen in my head neck posting once, and even I have a friend who has XP.
Oh, okay. But most people would not have seen a case of Xeroderma pigmentosa, but I think the clinical presentation is such. I've shared some of the slides which he will show with Rahat, that if you see once a case of XP, a full-blown XP, and of course, like all syndromes, and there could be very milder phenotype also, but if you see the severe or the typical characteristic phenotype of a XP, you will never forget. It is a spot diagnosis. Okay.
Approximately 25% of these patients will have progressive neurological degeneration with progressive loss of neurons, and which are probably linked with oxidative metabolism and DNA damage. And they have nearly 10,000-fold increase risk of skin cancers under the age of 20 years. And the average age of onset of first skin cancer is 10 years, and they have exaggerated response to UV radiation exposure with pronounced burning and blistering on minimal exposure to sunlight. They develop freckle-like pigmentary changes in sun-exposed areas, which appear as poikiloderma. And this freckling appears before the age of 2 years. This is what a clinical presentation of XP would look like. On the A diagram shows this child has blistering erythema in the malar region, and the forehead is spared, which was protected by hat. The B diagram shows this girl has freckles, and she even has SCC on upper lip. C diagram shows the nodular BCC on root of nose, and D diagram shows this patient's wearing hear aid for sensory neural deafness. E diagram shows this patient has corneal clouding, and F shows a sharp demarcation between the sun-exposed areas and the non-sun exposed areas. And G diagram shows telangiectasias and loss of vermilion border atrophies. The cells of XP patients are hypersensitive to killing of UV radiation and by UV radiation mimetic chemical compounds like benzopyrene in cigarette smoking. And the UV radiation exposure of the DNA produces several types of stable dipyrimidine nucleotide photoproducts, and the major photoproduct is cyclobutane pyridine dimer. These DNA lesions they serve as substrates which are rapidly repaired by a nucleotide excision pathway. These protoproducts are not repaired in XP cells, and they lead to pre-mutagenic lesions. And the polymerases which bypass these photoproducts, they incorporate incorrect nucleotide. For example, incorporating T in place of C, and this will result in a TC photoproduct. And these C to T mutations, these are characteristic of XP. These are called UV signature mutations. A number of gene abnormalities have been detected, ranging from XPA to XPG, and these DNA photoproducts are recognized by several proteins, for example, XPC and DDP2. After recognition, DNA is unwound by XPB and XPD helicases. XPA protein maintains the open DNA in position, and XPF and XPG are endonucleases. The resulting gap is filled by DNA polymerase and ligase. So the NER pathway is closely coordinated, so that even if the one of the proteins are defective, the entire pathway does not function correctly. So these patients have increased frequency of both non-melanoma skin cancers and melanoma, and the UV radiation exposed areas of lips and tongue have increased cancers compared to deeper, more shielded mucous membrane surfaces. And neurological findings would be they have frequently absent deep tendon reflexes and high frequency hearing loss. They have delayed developmental milestones. They present with sensory neural hearing loss and progressive intellectual impairment, which may progress to slurred speech, loss of ability to walk, and difficulty in swallowing. Thinning of cortices are present, and with concomitant dilation of ventricles. So hypothesis for this neurodegeneration is generation of free radicals by oxidative processes. And patient under 20 years have 50-fold increase of cancers of brain, which would include medulloblastoma, glioblastoma, astrocytoma, and schwannoma. And these are not sunlight exposed tissues, and their relationship with these cancers and DNA damage is not known. One important thing to note is, the X-ray damage is different from the UV damage, and these X-ray repair systems are normal in XP cells. So patients with XP who develop these eye tumors and other internal tumors in brain and spinal cord, they can be treated with high dose X radiation. So the family is guided to the skin and eye protection, sunblocks, protective clothing, and window tinting. And these children may develop freckles, but the family should have knowledge to avoid most of these damage. And these patients now can live a healthy, fulfilling life well into adulthood, and despite these skin cancers. And we still do not have any effective intervention for this neurological decline. So this is a case of Xeroderma pigmentosa in TMH, and this patient had multiple skin cancers, SCC and BCC over face. And on germline testing, homozygous mutation of XPC gene was detected.
Sorry, I forgot to hide his identity close. I think I had put, you have removed that. Anyway, I had closed his eyes, and you have to see there are eye lesions. It's all right.
Okay.
I had he covered his eyes. That I think he removed it to show that he also has multiple lesions on the eyelids and conjunctiva. So this is very severely, damages the skin. Multiple excisions. He has lost his nose, and a nasal prosthesis was made. So this patient has a mutation in XPC gene, and these are homozygous mutation. That means both copies, or biallelic, or both copies. So autosomal recessive. So go next. So what is the most important thing? Suppose A 10-year-old boy comes to you, pigmentosum, and he has one small basal cell carcinoma over the ala of the nose. So what will be the most, I think, Amir, you please answer this question. So a child comes to you, 10 or 12-year-old boy, normally typically they would come around that age. And so what, and it's a small BCC that you excise with clear margin. So what else would you do? You would just send that child home and then ask to come every 3 months, 6 months, or any specific advice would you give? And you will tell the child as well as the parents. So I want to hear from you, please. And since you said you also have a friend who has XP, so you must have gone, thought about it more carefully, or your friend might have shared with you what he or she was told.
If a child comes to me, like what you have told me,
so 10-year-old,
10
clinical appearance of an XP and a BCC. Actually, one thing I would just want to say. So each different, like if we were a large neurology unit, we would see generally XP which have neurological manifestations and of course skin manifestations. All XPs would have skin manifestation, but only some types of XP, different XP syndromes, they would have neurological manifestation. Whereas here, what we see XP cases. I have now more than 23 families, and except one, none of them have neurological manifestation. It doesn't mean it doesn't happen. They don't normally come to us. Whereas if you are a large or a referral ophthalmology unit, you will see predominantly XP cases which have conjunctival or eyelid problem. Okay. Yeah, Amia, you please tell what advice will you give to this 10-year-old boy or the parents?
First, I will tell them regarding what disease he has and what implications it will have on his life and on his day-to-day life. For example, this boy will have difficulty in going out in the sun and playing like his normal friends would do.
No, he doesn't have any difficulty. He goes out happily and plays in the sun, cricket, and comes back. He doesn't have difficulty.
No, but he may develop as in clearing up of erythematous reactions and that because
like a 10-year-old boy, he hardly notices anything. If he gets a chance to give a slip, he will go out and play. Okay. So what is the punchline? What is the advice that you will talk to the parents? You have to talk to the parents for 2 minutes. What are the key points? Okay, bullet points. If you can say that, you have to feel that you have explained and they have understood.
So the first thing will be protection from sun exposure.
Protection from sun exposure.
We using adequate amount of the sunblock and proper sunscreen and protective clothing, and just frequent visits to the dermatologist to look for any suspicious lesions in the body. Because the boy himself cannot notice all the lesions which he might be getting in difficult areas, non-exposed areas. Then I think proper hygiene also I will ensure, because these patients may have cutaneous infections.
Okay, I think you have covered most of the things, but I'll just sort of summarize it, put it other way. First, you explain to them that what the condition he has, that their child has, the son has, is a genetic condition which is autosomal recessive. That means both the parents may be carriers, but because they are carriers, only one copy, they don't have this. So you also inquire about the other siblings. Does any other, if it has another sibling, that person has. Okay. Then the second thing is you have to mainly emphasize that what you are seeing today is because of the sun exposure, cumulative sun exposure over the last many years during, for instance, childhood. And explain to them that this boy is at a very high risk of developing more skin cancers. Mostly they would be curable at the detected early stage in the sun exposed region. So it is very important that they keep coming for frequent follow-ups, either with you or to a dermatologist, and also keep observing and explain to them the importance that if a skin cancer is treated at a very early stage, you can preserve as much of normal tissue. Like the picture you saw, this boy has lost his entire nose. So, and that is happening because the cancer is advanced, more tissue is removed to get a wide to the clear margin. So earlier detection, you would also preserve more of tissue. That is very important. So that you have to explain. And then you say that he's only 10-year-old. There's a very high chance that he will continue to have more of sun exposure. Like a typical 10-year-old, he would not listen and emphasize why it is important to minimize the sun exposure. And then you find out whether they live in a village or in the city or in a high rise. Depending on that, you have to give them advice to minimize the sun exposure, because the worst thing that you can have is when he grows up as a young man, he has so much of facial deformity that he loses his nose, face is disfigured. And also about the eye also you tell, not just the skin exposure, because as you saw in this boy, he has conjunctival or lid lesions, and then the lid is destroyed, and then constant watering. So all these are very important things that you have to tell them, and they should lead as normal a life as possible, but obviously with restriction. And you said sunscreen. See, when you go on a beach holiday, you apply sunscreen, it's a different thing, or you go out for a few days. But all your life, all the time, you cannot live on a sunscreen. So I think the clothing, the general restriction, so he can go out when not during daylight. If he goes, after this, towards the sunset time, there's no problem. He can go out and play even outdoor activities, but not, it is blaring sunlight, and he has to go wear, and not the normal cap like the cricket umpires, they wear a round hat, that kind of hat they wear. And small children, sometimes their friends tease them, important the glasses which are either photochromatic or big glasses, not just the small glasses which sort of cover the eyes, these kinds of things. And full sleeves shirts, socks, and if in the north, whenever you can wear gloves at all. So that is very important. And this is applicable for the next cases you will be showing on albinos also. So that's why it is covered. Okay, carry on.
Coming to Muir-Torre syndrome, it's an autosomal dominant with a variable degree of penetrance. It's a variant of HNPCC, and the underlying genetic mechanism is germline mutation in DNA mismatch repair genes, leading to microsatellite instability, and it results in malignancies. It's characterized by a single sebaceous gland tumor, adenoma or a carcinoma, and a minimum of one internal malignancy. This internal malignancy can be colorectal or genitourinary. Colorectal malignancies, they occur proximal to the splenic flexure, and the sebaceous gland tumors may precede or appear concurrently or follow the diagnosis of the patient's cancer. Sebaceous adenoma are the most common subtype, and they are yellow or flesh colored, and they are dome shaped umbilical papules, which represent sebaceous hyperplasia. And the most common location is face, and sebaceous carcinoma is a local lesion, and they do not metastasize. They can be completely removed, and usually they do not recur. And they are analogous to BCC in regard to their local invasion and minimal risk of metastasis and approach towards therapy. And as we discussed earlier, carcinomas of mammalian glands, they are frequently noted to metastasize, and surgical excision is the treatment of choice. And they even have keratoacanthomas, which are dome-shaped nodules with keratin-filled centers. And Fordyce granules are intraoral ectopic sebaceous glands, which appear as yellow macules or papules found on the upper lip, vermilion border, retromolar area, and buccal mucosa. These are extremely rare, and they should raise suspicion for MTS1. So MMR gene family, it includes MLH1, MSH1, MSH2, MSH6, and these are responsible for integrity and repairing base mismatch in DNA replication, and inactivation or mutation of MMR genes leads to accumulation of these replication errors, particularly in microsatellite regions. These microsatellites are short repetitive segments of bases in DNA, which are particularly sensitive to base mismatch repair. And about 35% of these patients will not have these MSH2 mutation. They'll have MYH gene defect, which is autosomal recessive. MTS1 was autosomal dominant. And in contrast to MTS1, which are associated with early onset colorectal carcinomas, MTS2, they tend to develop later in life. So a case presentation, a case of MTS would look like this. A case of a 57-year-old male who would be referred to oncology department from a dermatology department. And the dermatologist performed a shave biopsy of the papule on the left cheek, and biopsy showed sebaceous adenoma. And on further IHC testing, it showed loss of expression of MSH2, MSH6. And this patient had past medical history of colorectal cancer at the age of 32. And he was treated with chemotherapy and partial right hemicolectomy with ileocolic anastomosis. He even had history of squamous cell carcinoma of right clavicle, which was treated with excision. And he even had family history of malignancies, including breast and lung cancer in mother and renal cancer in father. And so a surveillance plan for this patient would be to undergo annual skin checks, colonoscopy every 1 to 2 years, and upper endoscopy every 3 to 5 years. And due to history of renal cancer in first degree relative and loss of MSH2 expression, annual screening of urological malignancies with urine analysis and PSA is also recommended. So management of this patient would be the presence of sebaceous carcinoma warrants lymph node evaluation. And extraorbital sebaceous carcinoma, they do not metastasize, only 1.4% rate of regional metastasis. So SLN cryotherapy or excision. Sebaceous carcinoma involving ocular area are aggressive and metastasized. Micrographic surgery with 5 to 6 mm margins, and FS to confirm sufficient margins. These tumors usually do not respond well to radiation, and it should be used only as adjuvant treatment to excision or in palliative cases only. And close cancer surveillance in these individuals and their family members. And because aminoglycosides have proven to be used in cystic fibrosis and Duchenne muscular dystrophy, they can even be tried in MTS and Lynch syndrome. This is another case of MTS in which the A diagram shows a sebaceous cyst which was resected, and this C diagram also shows a pedicle graft for squamous cell carcinoma of right ala of the nose. And in view of the rarity and strong association with MTS, this patient was screened for internal malignancies, and on colonoscopy, an ulceronodular mass was seen, and it was even evident in CT scan. This is the case that was present in our cancer genetics department, and he had a family history of colorectal cancer. He himself was operated for colon cancer, and IHC showed loss of MSH2 and MSH6 protein. A shows surgical excision of keratoacanthoma, and B shows sebaceous carcinoma over the nose. Coming to skin cancers in albinos, albinism is a disorder of pigmentation, and it's common in.
Go back to the previous slide. So, he had on IC loss of MSH2 and MSH6, but germline testing shows only MSH2 mutation. So, any one of you can answer this, please? You all know the answer? No. Anyway, I'll tell you. So MSH2, so the mutation is in MSH2, one of the 4 mismatch repair genes, and MSH2 forms a heterodimer with MSH6 to make one of the mismatch repair complex. So even if the mutation is in one, because they form a heterodimer, so that's why you will see a loss of both the proteins on immunohistochemistry. So that is one thing. And I think again in syndromes where they have a tendency for multiple and repeated cancers, multiple skin cancers, whether it's because of underlying genetic syndrome or arsenic exposure, one of the major principles of treatment is maximum tissue preservation, because it's not the first time they are getting this cancer at the same site on the vicinity. They may get more cancer, skin cancers, and just repeated surgery just with a view of having a very wide margin ultimately would result in quite severe disfigurement. So that you have to keep in mind. Okay, carry on. And in Indian patients, when I see them in the genetics clinic, we explain to them normally what happens that in India, because skin cancer and in all the countries where skin malignancies are uncommon, so we don't really talk much about skin lesions, and even if they go to their doctors, they will not take it seriously. So we explain to them that because of the underlying condition, you are at a much higher risk of developing skin cancers as compared to others with the same kind of pigmentation. So you go to a dermatologist, not to any of your local doctor, because dermatologists have the experience to distinguish between benign and malignant. Most other doctors, in countries where skin cancers are not high, do not have that experience. So it is very important. And any average practicing dermatologist would be able to distinguish between a suspected malignancies versus other skin conditions, which are also quite common. Yeah, carry on.
Now, coming to skin cancers in albinos. Albinism is a disorder of pigmentation. It's commonly seen in blacks in sub-Saharan Africa, and oculocutaneous albinism is an autosomal recessive disorder characterized by a heterogeneous group of mutations involved in melanin synthesis. So most common mutation is mutation in tyrosinase gene, which affects up to 50% of the cases. Ocular features include nystagmus, photophobia, foveal hypoplasia, and decreased visual acuity. Lack of melanin in the document predisposes these individuals to cutaneous malignancies. Actinic keratosis progressing to SCC is most frequently reported. SCC is most common, followed by BCC, and even rarely a malignant melanoma's amelanotic variant is also noted. So melanin, a few words about melanin. Skin pigmentation is determined by number and the metabolic activity of melanocytes in the basal cell layer of the epidermis. The melanogenic activity of the melanosomes in these melanocytes, difference in the number, size, distribution of melanosomes, differences in the types of melanin, and differences in the degree of arborization of these dendritic processes of melanocytes. So melanin biosynthesis is regulated by these factors and MSH hormone. And one of the important function of melanin is protecting skin and eyes from harmful effects of UV radiations. And these melanocytes, they are derived from neural crest cells, and a number of genes control proliferation and differentiation of these neural crest cells, which may be mutated. And the transfer of melanin to surrounding keratinocytes and production of nucleocap protect DNA from UV ray damage. So there are many types of OCA, and OCA1 and OCA2 are the most common types. OCA1 is loss of function mutation in tyrosinase enzyme, and this is responsible for biosynthesis of brown-black eumelanin and yellow-red pheomelanin. And OCA1A has completely non-functional tyrosinase, and whereas OCA1B has semi-functional tyrosinase activity. OCA2 is the most common form of albinism, and it is characterized by mutation in OCA2 gene that involves in transporting proteins to melanocyte and stabilizing melanosomal protein complex. Physical development, intellectual quotient, and reproductive health are not affected in this disease. This is a case of oculocutaneous albinism in our department, and this patient had SEC in pre-auricular region, for which a surgical excision plus a skin graft was performed. A few words about contribution of radiotherapy in.
Just go back to the previous slide, albino. So if you remember this man who had a XP, his nose was destroyed, whereas this man who is an albino, he has a cancer in the preauricular region. And can you, and any one of you explain why albinos have a predilection for cancer as this site near the ear, and as well as XP cases have around the nose? Just think. What are the other features? Something else I've written about him. What else he had? So
actinic keratosis also.
No. So these patients, because they lack pigment everywhere, including retina and iris, so they have very severe photophobia, and that because they also have nystagmus. So anyone who has photophobia, they will look away from the light. And anyone who's looking away from the light, if you are outdoors and you're looking away from the sun, what you expose your this temple region or the ear. So maximum UV exposure is around that region. So that both these cancers are due to UV exposure. This because there's more of UV which goes in, and in XP, the actually less amount of UV goes in because there is pigmentation, but still whatever little UV goes in, they have a defect in the nuclear excision repair pathway, so the damage is more and it is not repaired. So through different genetic mechanisms, the same effect is produced. Yeah, next. Oh.
A few words about contribution of radiotherapy to problem of skin cancer.
I requested, because last time we were talking skin cancer, radiation, fractionation, we had not mentioned the name of Magnus Strandquist. So I requested Rajiv to say a few things about him, and then we will have a discussion.
Early experiments, Riesner found that 12 daily fractions of 20% of erythema dose, or 4 fractions of 60% of it delivered on 1st, 3rd, 7th, and 10th days produced the identical results as compared to a single application of 100% of erythema dose. So Riesner estimated a loss of effectiveness of first irradiation to be in order of 35%. And Quimby and McComb also noted the same thing. So Strandquist, he plotted graphically the dosage given to the failed cases of skin cancer, and he found a zone of optimum range. And this band, it separated failures due to underdosage and failures due to overdosage. And he carried out a study on 183 cases of BCC, 74 SCC, and 23 lower lip cases from 1934 to 1941. And it varied from a single massive dose to others who received daily radiation over a period extending up to 6 weeks. And a double logarithmic graph was plotted and a straight line was obtained. And he found that a single dose of 2250 rads delivered in one setting is equal to a total dose of 4200 rads delivered in 6 days, and 6000 rads fractionated in 30 days were equivalent. And the slope was 0.22 for the Strandquist curve, which was in accordance to the previous observations by Quimby and Riesner. And he concluded that longer fractionation required larger total doses. And this B in this graph represents the area of that band, which represented the cure for skin cancer. That's it, sir. Thank you.
Thank you. So, okay, yeah. So this is a cartoon which Strandquist was also a cartoonist during his MBBS days. Interesting cartoon. He's drawn as professor taking rounds. So any of the practicing radiation oncologists want to share some practical tips when you are giving deciding whether surgery or radiotherapy for a skin malignancy, or if radiotherapy, what are the considerations you would like to have? Any one of you? Or who's the SR with you today?
Dr. Amrendra.
Amrendra. So just in a one or two lines, when do you prefer radiation over surgery, or vice versa, for a skin cancer? And we're not talking of melanoma, okay? We're talking of non-melanoma skin malignancy. So what are the considerations, at least let us say?
Sir, so
Yeah, tell me, Amir. Yes, Amir.
sir, definitive radiotherapy can be offered in patients who are not surgical candidates. Like,
So why? I mean, is it because of GF fitness? I'm not talking of that. So we're not talking of very old and infirm. That is one category. Okay. I mean, a 90-year-old nonagenarian, and is just, that's a different set. Someone who is say 65 or 70 and can have short term GA.
so depending on the sites, for example, sites like nose and eyelids, where surgery can lead, along with the wide margins, can lead.
Just one thing. So functional and cosmetic outcome. Okay. So for different sites, there are different impacts. So functional and cosmetic outcome of surgery versus radiation. That is one of the key deciding factors. And I'm talking of non-melanoma skin cancers. Now, in terms of radiotherapy, any one of you, any participants would like to share or say something or pose any questions? What are the considerations in and I'm not talking of adjuvant radiotherapy, talking of definitive radiotherapy for any skin malignancies. We have 5-6 minutes for discussion. No? So last week you all had several slides. So first of all, what are the main things you have to decide? Okay, one, you have to decide what machine, what energy to choose. Okay, not many centers outside the Western world or Australia where skin cancers are very common. We will not have superficial or deep X-ray machine. So we only have either cobalt or a LINAC with or without electrons. But most centers now would have electrons. If not in your center, some other center in the city would have a machine with the electrons. And brachytherapy or surface mold may or may not be available. Now, the expertise to make a surface mold may or may not be available in your center. So there'll be some centers, they have a choice from superficial X-ray to a surface mold to electrons or photons with a bolus or whatever else. Some centers, they have only electrons, and some centers may not have even electrons. So let us assume a center which does not have a constraint on the kinds of radiation you can choose. That's the first thing you decide, which is the best way. So in terms of deciding whether surface mold or external beam, what is the main deciding factor? Surface mold versus external beam?
So depth of the tumor.
The surface mold. So one thing is that the lesion is not very deep, just few millimeter. What is the other main consideration? Last time Ashwini had pointed out. So in addition to the lesion being superficial, what is the other very important criteria which should be fulfilled? Then only you would consider surface mold.
Sir, the surface should be flat.
So flat. Plus the other thing is, the surface mold should fit very, exactly in the same. If it is preferably over an underlying hard, like a bony or a card, this thing. So where it is not very soft and flabby. Okay. So where you could have the surface mold can fit exactly into the same position and without any air gap, and be able to reproduce that. So these are the two things in surface mold. And in surface mold, last time I had requested all of you to go back and read the Patterson-Parker rules about the edge or the height why it is so important, and how it is used in construction of the surface mold. And mind you, today we do a cross-sectional imaging, you do a CT scan. But in earlier days, when the surface mold treatment was evolved, there was no CT scan, there was no ultrasound also. So based on clinical, fortunately, in most of the cancers, unless until they are very advanced skin cancers, you will be able to very reliably assess the depth of the lesion. Okay, because the skin thickness of the skin, both epidermis and dermis together, ranges anywhere from 2 to 4 or 5 millimeter, not more than that, in different regions of the skin. Like in the back, it is much thicker. In other places, it is much thinner. So surface mold. In external beam, once you have chosen, okay. So what is the main advantage of using a superficial X-ray? So let us say 90 kV X-rays or 120 kV X-rays as compared to electrons. Is there any major advantage of that over electrons? Just the main thing.
So the surface dose is maximum.
What?
The surface dose is 100% the.
So, I mean, with electrons, if you are concerned about surface dose, you can do various things, including a bolus. So, but what is the major advantage of, say, superficial or a deep X-ray over electrons? That
use
is a
smaller field sizes.
what? Say that again.
We can use smaller field sizes, sir.
So for small and irregular field sizes, the dosimetry of electron is much uncertain. The uncertainty is much more, okay, as compared to when you're using, say, 120 kV X-rays or 90 kV X-rays or whatever, 60 kV X-rays. So that is so irregular. You're treating near the eyelid or near the inner cancers, where it is a small irregular 1.2 or 1.5 centimeter square area. This thing with surface, and plus field shaping is also very easy in that. In electrons, it will not be. So this is the key thing. So if you are working in a department which gets a lot of skin cancers, especially in this region, small skin cancers, that is very important that you have this machine. Okay. Now, in terms of dose fractionation, what are the key things that you have to remember in terms of dose and fractionation? So Strandquist, let us ask, what is the major drawback or criticism? Of course, you have to respect what Strandquist produced was really phenomenal, but like any greatest, it is not possible. So what are the major things which have not been incorporated in the Strandquist's plot? So what is missing in the plot? No, anyone? I think last week I had just briefly mentioned also. See, when Strandquist had not taken into account, what was not taken into account in Strandquist plot, when he just show that curve, Strandquist. Go back to the slide. Okay, your slide is not moving. So he had taken into account the total volume was not taken into account. That is one thing, and volume has a very major impact. So important. Just any one of you can give me an answer. So skin, it is in parallel or series. It is in parallel. Okay. So volume is so important. Let me, I think did extensive work on skin, because skin was the biggest enemy. Skin was the biggest
So skin was the biggest enemy. They used to get skin reaction, and as a result, they could not go beyond the tolerance doses of the skin. So a lot of studies were done on to see how the skin dose is not exceeded. So they knew that volume is very important. So if you a larger volume gets much higher skin reaction, and smaller volumes helps because in a smaller volume the cells from the adjacent normal healthy skin, they would migrate, and the migration rate was about 0.5 millimeter per day. Plus the cells, in the hair roots and all used to help in reepithelialization. So volume was not taken into account. Plus he had not differentiated between healthy and healthy skin versus ulcerated skin. That was second thing. Plus was used when the volume was large, because radiation oncologists knew that. So that was not corrected. So these are the caveats in the Stenquist's plot which you have to be aware of. Okay, I think we will end with this, and I think in continuation with the skin, next week let us discuss about management of acute, so prevention and management of acute skin reaction as well as late skin reaction caused by radiation. Okay. So whichever is the group next week, who are the people for next week?
Sir, Amrita.
Amrita. Okay. So next week we will talk about acute and late skin toxicity due to radiation, its prevention and management. Okay.
Okay, sir.
Okay. Bye. Bye.
Thank you, sir.
Thank
Bye.
you, sir.